risk for ROP should be screened for retinopathy of prematurity. In Germany, they modified these protocols according to their register, RetinaNet register and EU ROP register, and added the requirement of supplemental oxygen to be a minimum of 5 days. India, for example, they screen bigger and older babies for ROP. So going back to the importance of the register study and that the development of national cohorts to adjust the screening protocols and treatment protocols to the patient's need and population needs. Now, going back to the IC-ROP, that's the IC-ROP zone definition, and we will summarize the main components. As we know, zone 1 is a circle centered on the optic disc with a radius twice the distance from the disc to the fovea. It's the smallest and the most posterior zone. Zone 2 is an area extending from the edge of zone 1 temporally to the nasal or serrata here. And zone 3 is the remaining temporal crescent of the peripheral retina. By clinical examination, we can define zone 1 by centering 28 loop or the 28 lens around the optic disc, and you can say that's this zone 1 that you are seeing with your 28 lens, diopter lens. IC-ROP 3 from 2021 added a subdivision of zone 2 closest to zone 1. It's the posterior zone 2, and it's 2 optic disc diameter into zone 2 from zone 1. This is a critical nuance because the more posterior the disease is, the more aggressive it tends to be. The IC-ROP defined the ROP stages too. As we all know, stage 1, here's the clinical finding, fundus photography or clinical examination, and here's the corresponding stage 1, 2, 3 in OCT imaging. Stage 1, demarcation line, faint, flat, thin line, separating vascular and avascular retina. Stage 2, ridge, bit elevated, broad, and three-dimensional. Stage 3, ridge with new vascularization, as we see here. With extraretinal fibrovascular proliferation growing from the ridge either into the retina or into the vitreous. There are phase 4 and phase 5. As we know, phase 4 partial retinal detachment and phase 5 total retinal detachment. The IC-ROP introduced more diffuse or wider definition of phase 5. They defined it in subcategories. Stage 5A, in which the optic nerve disc is visible by ophthalmoscopy, indicating open funnel retinal detachment. Stage 5B, in which the optic nerve disc is not visible due to either retrolental fibrovascular tissue or closed funnel retinal detachment. And stage 5C, in which the stage 5B is accompanied by changes in the anterior segment, such as marked flat anterior chamber, iridocorneal lenticular adhesions, and corneal opacities. We define the extent of disease as 12 sectors using our labels. So what's new or old and new, that's 4 years old. The IC-ROP 3 presented a broader definition of plus disease. Plus disease, as we all know, is defined by the appearance of dilation and tortuosity of the retinal vessels. And pre-plus disease is defined by abnormal vascular dilation, tortuosity that is not sufficient to be plus disease. The IC-ROP committee recommended that the plus disease spectrum be determined from vessels within zone 1 rather than from only vessels within the field of narrow angle photographs and rather than from the number of quadrants of the abnormalities. And it defines the plus disease as spectrum. If 2 ophthalmologists or two retinologists or pediatric ophthalmologists saw the same patient, they can quantify this plus spectrum differently. And the same ophthalmologist can define the same stage of the plus spectrum differently in two different occasions. So they presented us with outline that we can consider it and follow up with it to diagnose plus disease spectrum. What's interesting in the ICROP3 and the most important addition on ICROP3 was the description of the disease reactivation. Anti-VEGF agents have created new situations where disease regressed and then reactivated in ways we had never seen before. These images, for example, shows reactivation of diseases. The image number 1 at age of 67 weeks post-menstrual age, and image number 2, 50 weeks post-menstrual age. Both patients became twice anti-VEGF therapy. As we notice, the reactivation is seen more frequently after anti-VEGF treatment than following spontaneous regression, and rarely, if ever, occurs after complete laser photocoagulation. Reactivation may occur after incomplete or complete regression of the original ROP lesion. And although the maximum time interval until reactivation after anti-VEGF therapy is unknown, current evidence suggests it occurs most commonly between 37 to 60 weeks post-menstrual age. However, this may be affected by the choice and dosage of anti-VEGF agent and may occur significantly later if re-injections are performed. Signs of reactivation range actually from development of new self-limiting demarcation lines to reactivated stage 3 with plus disease. The reactivation may not progress through the normal sequence of stages of the acute phase disease. So we mean by that from stage 1 to 3. It may skip stages. So ICROP3 clarified the regression. It's not the disease process in reverse. Regression simply means the disease is going away spontaneously or in response to treatment. With anti-VEGF treatment, we see that regression can occur very quickly, 1 to 3 days after the injection, with reduced dilation of vessels and less tortuosity of the arteries and vein. With the laser therapy, it may need 10 to 12 days to see a significant regression, or some talk about 7 to 14 days to see a significant regression. So the ICROP3 defined the persistent avascular zone. Persistent avascular zone was introduced into the ROP lexicon, and it means that blood vessels failed to grow to the front of the eye or to the anterior of the retina. There is a belief there may be a higher risk of persistent avascular retina after anti-VEGFs than after spontaneous regression that we see frequently now. We need to compare the occurrence of the persistent avascular retina in eyes with spontaneous and treated regression and with incomplete laser therapy, we can still see persistent avascular retina. ICROP3 defined the notch. The notch is used to describe the penetration of the ROP lesion into a more posterior zone, 1 to 2 hours. The ROP zone for such eyes should be indicated by the posterior zone of the retina vascularization with the addition of the word notch. For example, we can call here that's zone 1 due to notch, although it's 1 to 2 hours in zone 1, mostly in zone 2, but it's zone 1 due to notch. ICROP3 presented wider definition of aggressive or new category of the aggressive retinopathy of  ROP or aggressive ROP includes the aggressive posterior ROP formerly known as rush disease, which was first recognized in 2005 to designate a rapidly progressive posterior form of ROP that can bypass the typical progression of the stages. ROP, the aggressive ROP, include peripheral features such as vascular loops and areas of avascular retina, sometimes without obvious demarcation lines or margins. Here can fundus fluorescence angiography more accurately visualize the vascular changes in this disease spectrum or disease entity. ICROP3 defined the long-term sequelae, and they emphasized them such as late retinal detachment, macular anomalies, including small foveal avascular zones or retinoschisis, retinovascular changes such as persistent tortuosity, late development of lattice degeneration areas, and glaucoma, mainly secondary angle closure glaucoma. Therapy recommendations for ROP patients. Usually, we treat zone 2 at any stage 3 with plus symptoms. Before that, we used to treat 5 consequent clock hours of ROP or 8 scattered. In my late praxis in Germany, that was regardless of the number of hours affected. Whenever we see stage 3 in zone 2, we treated the patients. Zone 1, always with plus symptoms, and stage 3, and aggressive ROP in zone 1 or posterior zone 2. I don't know, maybe Dr. Christiana will add something about the therapy recommendation. So, follow-up examination in retinopathy of prematurity. Normally, we follow every 2 weeks. Weekly, we follow in zone 1, posterior zone 2, and when the vascularization limit is anterior zone 2. We can examine every 2 or 3 weeks in any ROP, when the ROP stabilized. We can examine more frequently in any ROP forms in zone 3 with plus symptomatic, shorter than 1 week interval for rapidly progressive ROP, aggressive ROP, or very immature retina-owned, very immature babies. Treatment modalities, we all know about the obsolete cryotherapy. Many consider the laser photocoagulation as the gold standard therapy. Anti-VEGF agents, they are mainly for choice for zone 1 or posterior zone 2 ROP, and it's the rising standard of therapy. And surgical therapy for stage 4, mainly B, and stage 5 retinal detachment. The recommendation of therapy were given according to various studies. Laser coagulation according to the ROP studies, anti-VEGF, the off-label therapy of bevacizumab of some areas, ranibizumab, it's now the ranibizumab and aflibercept, the choice of anti-VEGF agents after the 2018 ROP study, 2019 Rainbow study, and 2022 the Firefly study for aflibercept. For these medicaments, there is low volume precision syringes with integrated dose control function. The VisiSure is from the Lucentis company, and the Bicleo from the Eylea company, and they present you can provide the dose very accurately with these low volume precision syringes. As we know, the dose for babies are 0.2 milligram of ranibizumab given as an intravitreal injection in 0.02 milliliter. Aflibercept has 0.4 milligram given in 0.01 milliliter. It's important to give the babies the right dosage, because at birth, not talking about the premature babies. A baby's eye are already about 70 to 75% of their size in adulthood. But the size of the eyeball in premature babies can vary and can be very small. Please consider that the lens of the babies are abnormally large in proportion to the baby's eyes or the preemie's eyes. So please don't hit the lens while injection. Post-operative follow-up, either for laser or for intravitreal injection. Normally, we examine 5 to 7 days after treatment and should be continued weekly for signs of decreasing activity and regression. Retreatment should be done 10 to 14 days after the initial treatment when there has been a failure of the ROP to regress. We are talking about the anti-VEGF therapy. In anti-VEGF group, treated patients, follow-up examination should continue for at least 6 months. And when we reach stabilization or regression of ROP or stopping of the ROP of this patient, we continue to examine the patients every 6 months until they complete the 3 years of age. And after that, once yearly until they complete the 6 years of age. We know there's other associated risk and visual problems with the ROP patient aside from the retinopathy of prematurity. So we need more understanding of vascular endothelial growth factor and insulin-like growth factors in retinopathy of prematurity. We need more evaluation of their systemic effects, systemic side effects. 10 years ago, only 10% or fewer cases of posterior ROP were treated with anti-VEGFs. 2015 to 2017 was at 75% of cases used anti-VEGF as the first-line treatment. Last year, we made a cohort in my university clinic in Düsseldorf, and out of the 98 examined ROP patients, we treated 9. 7 from them received anti-VEGFs and 2 received laser therapy according to the request of the patient, of the parents. There remains too many open questions regarding the therapy and examination and follow-up of retinopathy of prematurity patients. As we said, long-term consequences, that's not once disease. You need to follow the patient up for a long period of time. Persistent avascular retina needs more wider discussion, more studies, the definite type of treatment, how long can we wait until we treat this part retina. We are talking about retina after anti-VEGF injection. After appropriate laser therapy, we barely see persistent avascular retina. We need to monitor the macular and retinal and systematic abnormalities. Sorry. As we said, other countries have different guidelines for screening and treating their own population, adapted to their own neonatal parameters. We need a national cohort. I asked Dr. Khalil, maybe we can progress in this subject and maybe in a partnership with other centers to make a pilot study, some small cohort group to collect our ROP patients, management, how our patients respond to therapy, how's the risk. We need that. We need to study more about the genetic correlation. Now the wide-angle OCT, telemedicine, and artificial intelligence are playing wider role in treating premature patients. So again, early screening is paramount. Right time screening, awareness, systemic support, that's multidisciplinary teamwork with the neonatologist, the pediatric ophthalmologist, the retinologist, and vitreoretinal surgeon. We need them. So we need the multidisciplinary teamwork to improve the life of these client beings. Thank you. Sure.
Thank you, Dr. Khalil, for inviting me. And thank you for this comprehensive review. It was a really comprehensive review with all the updates that are needed regarding classification and the new trends in treatment. So, a few comments regarding screening. We can't emphasize enough how important screening is. It is different by countries. So, each country is different. In the US, the limit is 30 weeks, and 1,500 grams. Here in Lebanon, we do 32 weeks and 1,500 grams like you do in Jordan. In some areas of the world, like India, they screen older babies. And I know there's one report from Jordan that came reporting older babies that needed actually laser treatment, and they were above 34 or 35 weeks of gestation, I believe. So we have to coordinate with the neonatologist and identify children and infants that are at higher risk, those that receive more oxygen, those with risk factors, maternal and neonatal and perinatal risk factors. The also the new classification and the new guidelines in 2021 mentioned adding growth, a certain amount of growth within 1 to 2 weeks. Anything below 200 grams weight gain, then also they screen the babies. But they also emphasize that these we cannot generalize. Each country is different, and developing countries are different from our area of the world. In the developed countries are different from developing countries in that regard. Screening, and of course, there's the new AI tools, but we're still far from implementing those. They need a lot of regularization and standardization. So that's as far as screening. And of course, as Dr. Ala mentioned, the rest of the new guidelines with the peripheral avascular retina that we're seeing more of now with the anti-VEGF, because we're not lasering as much as before. And also the notch, the continuum of plus disease, that is not just one, like the photo of plus disease. There's pre-plus, and then it continues up to plus disease. And the aggressive ROP, the rush disease that we are seeing not only in the posterior zone, but also even more anteriorly. So it's called now aggressive ROP. Regarding treatment, what we do and what is most time now implemented is that, and most of the time agreed on, is that laser treatment is still the standard approach. This has to be discussed with families. As Dr. Ala mentioned, sometimes we discuss with families, and we may opt to start with an injection. We have to always remember recurrence rates are much higher after anti-VEGF. Monitoring is very crucial in those babies. The recurrence has been documented in up to 65 weeks post-gestational age, and up to 69 weeks in one report. So we have to be careful with them. And as long as the family understands, and if they are reachable and follow up on time, then that's that. Otherwise, laser would be the safer choice. In our center here at AUBMC, mostly we use the anti-VEGF as a salvage treatment, as a rescue treatment. So we start with laser. People who do not respond, infants who recur, then we give the injection. Sometimes we may give an injection. We have to be careful with the peripheral avascular retina. So the retina person has to follow on them very well. We are cautious. We have to make the family understand that up to this date, we are not sure how the VEGF and as you know, it's important for their neurodevelopment, and studies keep coming up with lesser and lesser and smaller doses. So we may circumvent the neurodevelopmental adverse effects. So this is still not established, but time will come, and as time goes by, studies will unfold. The only FDA-approved treatment is with the anti-VEGF Eylea. It's the only one that's FDA approved now for ROP. I think ranibizumab, the Lucentis, has been approved in Europe. But the most widely used actually has been Avastin, and that's what we use here in our center. I'm happy to address any other questions you may have. What's your standard protocols in Jordan? What do you mostly do? Do you start with the anti-VEGF or with the lasers?
Kara Governmental Hospital, we are just a screening unit. I tend to refrain from intervening a lot regarding the management because, because of the all protocols and so forth. Injection wise, I tend not to do any, but we're just a screening center rather than, intervention. We just refer them to other hospitals. However, I was really interested in knowing how can we, does laser, or let's say, does anti-VEGF can a little bit lower the incidence of myopia in patients with ROPs?
So this is the advantage of anti-VEGF, or the hype and the excitement about anti-VEGF is that we are avoiding the ablation of the peripheral retina, so expanding the visual field. And as you mentioned very correctly, the rate of myopia is much less than those who underwent laser treatment. So the burden on the family is less. But the follow-up is different. And that's what is still not established. Yes. And we have to be careful as we choose the patients that we inject. Sometimes, if there is a risk of traction, they may worsen with an injection.
Yes.
Yeah.
I've been
So,
noticing even
it's better to be
the rates
selective.
of retinal detachment, dragging of the macula. What else? We mentioned myopia as well. All has actually gone down after the era of injections. I remember
Yes,
the
that is
first
correct.
time Dr. Mansour actually he did the first injection at AUBMC in 2008 or 2007 when I was a resident, and from then people started actually popularizing anti-VEGF for treating ROPs.
Doctor to be able to perform laser therapy in him, so we treated him with intravitreal injection of ranibizumab, and we tried to inject another one in ICU under the care of the neonatologist, and he arrested and got bradycardic maybe 5 times as we laid the speculum on the eye. So that was a failed trial of injection, and this baby was unfortunately very small and very unviable to survive, and he died, I think, 3 to 4 weeks later. So as you said, that's a benefit from the anti-VEGF therapy. We don't need a long time in treating these patients. So for the systematically unstable patient, not very unstable patients, we can treat them easier than treating them with laser, which we need more instruments, more time. And that's I think that's the problem. We need to choose the patients carefully, and sometimes we change our opinion instantly. We cannot proceed with the laser therapy, or we must stop now, or we can't proceed with the treatment at all. Yeah.
Right. Yes, there are certain cases where you have to directly go to injections, like an unstable baby. Like you said, it definitely saves time versus a 40-minute to 1 hour laser session. Also, when you have poor pupillary dilation, when you have a vitreous hemorrhage obscuring the view, when you have a partial retinal detachment. So, in some cases, the more optimal alternative.
Yeah. Thank you.
Hi, how are you all? It was an interesting presentation. From my side, as a surgical retinal perspective, it's tough to, from my experience here in Lebanon, it's always, I operated on stage 5 diseases with funnel detachments. It's very, very, very ugly surgery. Usually, it's bad prognosis once you see funnels. But you have to go into multiple surgeries if the retina folds well back. If you are able to remove the tractional elements and the fibrovascular proliferations. Sometimes you have to remove the lens also with these patients, depending on the stage and depending on the how anterior is the proliferation and how much funneling there is. It's always difficult. Screening is very important, and we always advocate for this. Now I'm working in rural areas in Lebanon. I always advocate for this in multiple NICUs and for pediatricians. I don't know if in Jordan it's the same or not.
Thank you. Thank you, Dr. Khalil.
Thank you, Dr. Khalil.
George.
Thank you. Good seeing you, Khalil. Thank you, everyone.